Good afternoon, everyone. My name is Ronald Corrado. Today we're going to talk about needle cricothyrotomy. This is a skill that I've chosen to demonstrate for my 15-minute presentation. As we work through this PowerPoint, I've got several pictures, I've got some definitions, I've got a video at the end that describes the actual procedure itself that I have performed and demonstrated, and I'll just talk through it as we go. I chose this because this is a skill that is a very low frequency, high acuity that we perform on our patients. It's one of those skills that you may go a full career and never perform one, but I feel like when it needs to be performed, it's something that needs to be done right then and there without delay, just due to its acuity and what's going on with the patient itself. So this first page, it definitely shows your objectives. With any presentation, you need to have objectives of what you're going to go over and things that you should learn and find out with this presentation. You can see our objectives are: we're going to define the actual what a needle cricothyrotomy is. We're going to give us indications, contraindications. We're going to list all the equipment that we need for this procedure, which is not a whole lot, but it's still equipment that you need to know what you need to have on hand to perform it. We'll do a quick anatomy review, and then like I said, at the end I've got a step-by-step presentation, and then I actually do the procedure in real time. So a simple definition of a needle cricothyrotomy is the introduction of an over-the-needle catheter device into the cricothyroid membrane to provide a temporary airway and oxygenation. That's the definition I found out of any paramedic book that you want to choose. That's the definition that you'll normally find for this procedure. So what are our indications? The end-all indication is your inability to ventilate or oxygenate your patient by any other means that you have on hand or that you've attempted. Different protocols will tell you, will lay out different indications, but that's your main indication. You're unable to ventilate or oxygenate that patient. What are some of these causes that may cause you this inability to ventilate or oxygenate? You could have a foreign body aspiration or obstruction. You can have some severe facial trauma, edema. Sometimes with infections can cause that edema. You can have swellings of the airway, whether it's traumatic, whether there's some kind of edema from an anaphylactic reaction, or you can have that external swelling from an injury that can, with any trauma patient. You can't really find a whole lot of contraindications because this is a last-ditch effort for these patients. The only main contraindication that you'll find a lot of times is if you can't locate your landmarks that we'll talk about in a little bit. You don't need to be sticking a needle in somebody's neck if you can't find where it's supposed to go to. Like I said, it's indicated as a life-saving last resort procedure in pediatric patients 11 years old or less of age. That is straight out of the NCOEMS protocols. And this can be also performed on adults, although rare, due to we have other devices that are available, whether you're doing a surgical cric or any of the pre-made devices that are out there nowadays. So as you can see, I've got a nice little picture here of all these simple equipment that you actually need for this procedure. What do you need? You need a 14 gauge 3 1/4 inch needle. That's what we carry at our service. Actually, any gauge needle that you have, a large bore, 14, 16. If you're doing this on an adult, you probably need a 3 1/4 inch needle. If you're doing this on a 1 or 2 year old, you might actually need an 18 gauge IV catheter. You might need something smaller. You do have to gauge that upon the patient that you're actually performing this procedure on. What I have is an adult mannequin that I'll be performing on. So I have a 14 gauge 3 1/4 inch IV catheter, angiocath. Also, what you see is I have a 3.0 ET tube. We'll talk about what we use, why we use that. You need a 10 cc saline flush. Do you need that? Not really, but it does help out to give you indications of your landmark, or if you're actually in the correct space. You need some kind of cleaning device that you can see over there. And what I'm going to show today is just the use of pediatric BVM once we have performed this, when you attempt to at least attempt to oxygenate your patient. Okay, real quick anatomy review. The landmark where we perform this needle cricothyrotomy is actually the cricothyroid membrane. Some of the studies that I've showed when I teach this at my job that I actually have and do this, I've been doing this for 25 years. I was always taught to start at the top and work your way down. What some of the studies I've researched is a lot of people are going too high and not staying midline, and actually we're losing the landmarks. So a lot of the studies now, they're actually teaching you to start at the sternal notch, which is easy to find on most patients. You kind of start, you work your way up, palpating the trachea as you come up. That first landmark that you find is actually a cricoid ring. The next landmark you find is the cricothyroid membrane. Actually, if you actually measure it, it's about 2 to 3 centimeters from the actual sternal notch. Here's my mannequin that I have that I've labeled out for us. So that way we can kind of see, you can kind of see where that sternal notch is. And if you go 2 to 3 centimeters up, you can see that cricoid ring. I'm looking at the picture on your left. The black dot is actually where that cricothyroid membrane lives. It actually lies in between that cricoid ring and that thyroid cartilage, the large shield-shaped the shield-shaped cartilage that is actually the thyroid cartilage. On the right-hand side, you can actually see I have my fingers pointing to actually where I've kind of marked that spot. All right, so we're going to talk about our equipment preparation. As you can see, the picture on your left is that 14 gauge 3¼ inch angiocath. We like using the angiocaths because they have that ability to, you can pop that back cap off. They're not a safety needle. So you have the ability to pop that back cap off. And as you see the picture on your right, you actually take that 10 cc saline flush and actually place it in the back of that IV catheter. And we'll talk about kind of how that plays in here in just a minute. But that's the nice thing about these IV catheters is if you have one of the safety catheters, regular IV catheters, you don't have that ability. So you kind of have to skip the step of the 10 cc flush and just verify your placement another way. So when we start talking about that 30ET2, what was it for? Well, actually what you do, you remove that adapter off the end of the 30ET tube, and what we use that for is that's actually good. You can connect different devices to that when we try to ventilate or oxygenate our patients. But you just pop it right off and set it right there, so that way as soon as you place that catheter, you're ready to place that adapter on the end of your IV catheter once you've placed it. So once again, you can see the picture on the left. I have my finger pointed at the black dot where your cricothyroid membrane is. What you want to do first off is find that landmark, mark it, hold it, and don't ever let go of it. So that way you don't have to find that mark again. From there, you take that catheter into your dominant hand. Make sure that 10 cc flush is already plugged into the back of it. You can see kind of how that plugs in. It just plugs right into the back of that IV catheter. You're going to take a 45-degree angle and puncture that membrane. You should feel a nice little pop. Once you feel that pop advance just maybe a centimeter more, draw back on that 10 cc flush. You should just get bubbles that indicates you're in that trachea, in that spot where you want to be at. So once we've placed that IV catheter into the membrane and we've confirmed our placement, we want to remove that needle. We want to place it to the side and place it in a Sharps container, and you want to have that catheter advance as far as it will off of the needle into the membrane, not forcing it because it will become kinked if you're not careful. So go as far as you can, and then once you feel meet resistance, kind of stop with that catheter, remove that needle, place it, and then from there you want to take that 30ET adapter and place it into the back of the IV catheter. And now we're ready to do the best we can with the procedure that we've performed, and hopefully we can somehow ventilate, maybe oxygenate this patient. We want to take that BVM, place it over that 30ET adapter. That's why we use it, because any BVM will fit it. I like teaching to use a pediatric BVM because you do have a pop-off valve that you have to override. As you can see on that BVM, my white, you should be able to see my cursor, the white override I've locked it over to pop off, so that way we don't have to that pop-off valve won't be in in play, and you'll be able to get a little more force. And from there, once we do that, we want to ventilate with an I to E to 1 second to every 4 to 5 seconds. Stabilize that IV catheter the best way you can with tape, or I think I prefer just to hold it in place so that way I know what it's doing and I can feel whether or not it's moving or not, whether or not it's moving. Okay, so now we have it to where I have my video here on the right hand side. And as we go through it, I'm going to play it. I'm going to pause it a few minutes as we go through, because I'll start with skill at the very beginning and kind of work my way all the way through, just pausing the video, and I'll kind of point out a few things as to how I do things. So as you can see, I have full PPE on. I have my gloves on. You can't see my face, but I have my shield, my mask and shield on, because you don't want to be sprayed in the face with blood or any other kind of substance that might occur with this procedure, especially if it's a bloody trauma patient. So you can see I have my mannequin sitting here. It's the same one I have with all my labels on it. You can still see my black dot right here on the mannequin itself. So I have everything laid out on a table in front of me, and we're going to walk through it here. And you can see as I start here, first thing I do is pop that 3 ET cap off. I take that catheter. We take that cap off the back of it. I'll go ahead and stick that 10 cc syringe in the back of that IV catheter. So now all my stuff is ready to go. I don't have to stop halfway. I've prepped everything quickly beforehand. So now everything is ready to go, and I can do it. Should be able to do it all in one nice smooth motion. So there, I find my landmarks. I have my cleaning device. I clean it. As you can see, I've got it in my dominant hand. I find a 45-degree angle. I slide that catheter over the end. I punctured it. I withdraw it. I'm going to go back here just a little bit just to make sure that I point something out here. Let's see. Back up here just a little bit. You can see, if you looked in that IV catheter, I'm going to play it one more time here. That 10 cc range. Let me back up here just a little bit further. You can see I drew bubbles back in it. From there, like I said, I withdrew it. I threaded that catheter as far down the needle as it would go. From there, what I do is take that 3 ET adapter, stick it on the end of the actual IV catheter, so that way I'm ready to put my BVM on it. Keep playing it here just a little bit. Go around, I fumble here just a little bit getting that catheter on there. But I get that BVM on there. As you see, I got PEEP on there, but not necessarily, you don't necessarily need a PEEP valve. That first ventilation that I had there was a little quick. That first one should be 1 second, and then wait 4 to 5 seconds. I think I did probably 1 to 2 there. And your ventilations or your oxygenation that you're attempting to do should be a nice full 1 second squeeze. You're going to feel a lot of resistance trying to push air through that 14 gauge IV catheter. It doesn't flow real well through there. But what you want to do is, you can see here as I do it again, I give a nice squeeze. There's a nice 1 second squeeze. But I usually I try to do that second one let's go back here for a second. Sorry about that. Let's play that. So there's, like I said, there's 1 second. So, but that's just a nice slow squeeze. Like I said, you're going to meet a lot of resistance. You got to realize these patients, if they have a high occlusion, they have some kind of laryngeal edema, and they're not able, that air is not able to exhale out or get out, that you could cause some barotrauma. So you've got to allow that patient a chance to exhale. If not, all you're doing is just pushing air in there, and you're putting more and more and more in there. Unless you give that patient the ability to exhale, you're going to start having some issues sooner or later. So you need to either just pop that BVM off, let it passively exhale as much as they can. If you're doing this for a trauma patient that you couldn't get them intubated or something like that, then most of that air is going to go back out the top. It's going to use that path least resistance. So you got to think about that too when you're doing these patients. What's kind of above that IV catheter, and is the air going where it should be? Hopefully it is. Remember, this is a last ditch effort, so we're not really going to get chest rise and fall. You're not going to hear lung sounds. You're just passively trying to push some oxygen down there to get them to a higher level of care to get a trach for this patient, or somehow or another an airway for this patient, so that way maybe they can survive this injury. So that's about all I have today. If you have any questions, feel free to ask me, or other than that, I'll be excited to see some other people's videos and see what they're going to teach me. Hope y'all have a good night. Thank you.